Hello and welcome. This is Kaban Kuchaypur from Computer Science Department here at NTNU. I would like to welcome you to our paper presentation, Learnings from an Old EHR for Child and Adolescent Mental Health. Our paper represents our study about a discontinued EHR system for camps in Norway, which is called BOOP data. We have studied BOOP data, which served camps in Norway until 2020, and interviewed stakeholders to recount the features and functions that made this EHR system successful. Our findings are based on some software artifacts and interviews with system designers, managers, secretaries, data users, and other stakeholders. All are done in order to provide guidelines and requirements for the IDs project, which aims to develop a CAMS-specific decision aid integrated in general EHR systems. In 1984, EHR systems were replacing paper records in Norway, and the Norwegian Association for Child and Adolescent Psychiatric Institution decided on having a common information system to support clinical work and improve quality of clinical practice. BOOP data was developed and fulfilled needs for collaborative care, practice insight, and service management. It was a try to meet the requirements of government, administration, clinicians, patients, and researchers. The development and then user training all were done for almost all camps across the country to provide the unified quality of care nationally. BOOP data had many important features. It had a successful full fast adoption because of local administrative personnel and secretaries who became responsible for introducing the system and training users. And also, a rich health domain information model contains of family history, collaborative care, supporting multidimensional classification, and allowing clinicians to represent the condition and progress of patient care. At the end, while some clinics have 30 years of using CAMS EHR with satisfaction, CAMS became integrated with specialist healthcare, and BOOP data was replaced in 2020 with a more general EHR system, offering less functionality and insight into CAMS practice. Our methods contains studying the existing documents and gathering not existing information by interviewing, presenting, and discussing relevant features and functions of BOOP data. So our main resources were system and design documents, stakeholders reports to understand organizational priorities and BOOP data objectives, and the last one, interviews with different groups of people, initial designers and developers of the BOOP data, clinicians, analysts, and managers, and office users and secretaries. Our goal was gathering information about functions and features, likes and dislikes, ambitions, and requirements of BOOP data. To identify the original decision-making behind the architecture and model design, we interviewed designers and developers of the system. To uncover usage and the requirements related to patient treatment and clinical use, we met clinicians. We talked to data analysts and managers producing and using the annual reports, and finally secretaries who were important agents for changes and main role players in translating clinical and managerial needs into developer requests. There were three important motivating factors behind BOOP data idea. First, possibility of comparing and improving practices of more than 70 decentralized CAMS clinics in Norway, and also rapid implementation and coverage. That all were because book data were developed and managed in small CAMS clinics with secretaries and managers very close to the daily clinic operations. Book data was the first EHR system in Norway to offer a secure patient portal, and also it was the first EHR system to fulfill national requirements for reporting activity on the level of individual care episodes to NPR. With book data, CAMS were early adopters of rich coding of the current patient condition and progress, having free text notes and also coding of activities, interventions, and diagnoses. Demographics, family, and care collaborator roles were modeled all in the records, and also enabling a rich view of patient condition and progress in episodes and long treatment processes with multi-axial, multi-diagnosis, state-based encoding of diseases. As other important practical results, we can say a simplicity of using book data for clinicians, administration, and managers. The simplicity was because of easy to navigate layout, simple interface organization, transparent functionality, clinically motivated data structure, and workflow support. Book data had a rich administrative functionality for assessment and reporting from the beginning. Also, it had some functionalities that used too little for research. Finally, CAMS collaboration with other services, roles, efforts, and interventions were coded explicitly in book data and led to development of multidisciplinary plan-based EHR. As our most important experience and insight, we understood that insight into own and local clinical practice is important and should be available to clinicians. Practice reports and quality assessment should always be available and based on live clinical data. Clinically meaningful, stable, and well-founded domain information models for structuring and validating coding information are very important, of course, if used by and for clinicians. We found that implementation and training should be tightly integrated with the service managed by individuals and directly gaining from system development and system deployment. And also, EHR systems should support patients with decades of history and complex collaborative care. The findings also reflect explicit challenges related to book data and EHR usage. CAMS has a domain-specific model. In particular, it allows representing processes of disease and function. EHR systems are vulnerable to health service reorganization. Data analysis functionality was underutilized because of limited resources. Book data architecture and EHR architecture in general were not ready for service integration. And finally, management failed to understand that collaboration and planning support was really crucial to CAMS. We learned that there is no need to integrate systems. Sometimes integrating services and interfaces are enough. It is important to keep the simplest working domain model. It is clinical and patients' needs that should direct information modeling. It is so important to make information available to those making it. While traditional diagnostic coding is event-based, but also should include long-term processes and changes. Data was an innovation with fast implementation, complete coverage, successful use with too much clinicians' satisfaction. That finally was replaced with a more general integrated EHR system, but as preserving the experience and heritage of book data. One final insight could be this, that future EHR systems must be designed to accommodate for future domain-specific, data-driven add-on decision aids. Thank you.